Hey, welcome back to Not So Complicated. And today we are tapping into the most ignored, most important topic, the portion of pathology, or you can say biochemistry. So, that is acute phase reactants for basic concepts and also for USMLE step 1. So, we are doing the overview of this, types of these, and the individual types, individual examples of positive APRs, negative APRs, and the functions of this, right? So, let's begin without further delay. So, what are acute phase reactants? These are plasma proteins whose concentrations not only increase, but there is a criteria for that, right? So they change by at least 25% during an acute phase response. Acute phase response to what? It is a response to infection or any insult to the body, right? So in acute phase response, these proteins change by at least 25%. That they are triggered by inflammation, infection, trauma, surgery, stress, anything that is an insult to the body, right? So acute phase reactions, they are produced primarily by liver. Their synthesis is driven by pro-inflammatory cytokines like interleukin 6, interleukin 1, and tissue necrosis factor alpha. They are released by macrophages and other immune cells. So this is the overview. There are two types of acute phase reactants. These are positive acute phase reactants and negative acute phase reactants. The positive acute phase reactants, they increase in concentration, so that is why they are positive. They increase in concentration to enhance immune responses, promote tissue repair, or limit microbial growth. So these reactants, these molecules, these proteins actually want to get the body out of that insult phase, right? So the examples of these are C-reactive protein, serum amyloid A, ferritin, fibrinogen, complement proteins, and haptoglobin. We will be talking about each of them individually. And in negative acute phase reactants, they are actually decreasing to conserve resources. Actually, they also want to body, like they want the insult to go away from body, right? But they decrease to conserve resources for positive APR synthesis. So they both are beneficial to the body, but they decrease to conserve the resources, right? So these are albumin, transferrin, transthyretin. Why they decrease to conserve the resources for the positive acute phase reactants? Because the positive acute phase reactants, they have major role to enhance immune responses, promote tissue repair, right? So let's talk about each of them individually. So C-reactive protein, it is the most tested APR, acute phase reactant. Probably you have heard of that, noticed that in many diseases, right? So it rises within 6 to 8 hours of acute phase response and or insult, and peaking at 48 hours. It binds to phosphocholine on pathogens. Pathogens have phosphocholine molecule, so this protein binds to that molecule, and then they act as opsonin. Opsonin is actually inflammatory response, like they act as opsonin, so they activate complement system. So complement activated response would be there if there is increase in C-reactive protein. Clinically, CRP greater than 10 mg per liter indicates infection or inflammation like sepsis or rheumatoid arthritis. So high sensitive or high sensitivity CRP, this HSCRP is a type of CRP. It predicts cardiovascular risk. So this is very high yield. You have to remember at least this one, most importantly, are in major focus, right? So the other one is serum amyloid A. SAA rises faster and higher than CRP, especially in viral infections. So in viral infections, serum amyloid A rises fastly. So it modulates HDL metabolism and recruits immune cells. The prolonged elevation of this SAA has a risk to develop AA amyloidosis, right? So if you haven't known or haven't attended the lecture of amyloidosis, this is in general principles of our pathology session in USMLE step 1 line by line session. You can visit that. It is shown in, or it is seen in chronic conditions like tuberculosis or rheumatoid arthritis. The other one is ferritin. Ferritin is actually the iron reserve of our body. So ferritin sequesters means it only conserves, sequesters iron means it limits the iron in macrophages to starve bacteria. So bacteria usually need iron, glucose to thrive, right? So this ferritin, this sequester iron to starve bacteria, rising in hemophagocytic lymphohistiocytosis, HLS, or Still's disease. The exam trap is that elevated ferritin, that is greater than 500 nanogram per milliliter, in inflammation can mask iron deficiency. So we have to check for TIBC or soluble transferrin receptor. So in anemia of chronic disease, there is a very high chance of developing iron deficiency anemia, because ferritin is sequestering iron to starve bacteria. So this is also very high yield. And the fourth one is fibrinogen. Fibrinogen promotes clotting and tissue repair. It drives erythrocyte sedimentation rate elevation in inflammation seen in lupus or giant cell arthritis. So this is less specific than CRP but critical for coagulation, that is our healing process. And the fifth one is complement proteins like C3, C4. C3 and C4 actually enhance pathogen clearance via the complement cascade, right? So C3 rises in acute inflammation, but C4 may drop in SLE. So this is very, very important point here. C4, like in common inflammation, C3 and C4 both rise, but in SLE, systemic lupus erythematosus, C4 may drop due to immune complex consumption, right? So the other one is haptoglobin. It binds free hemoglobin to prevent oxidative damage, and also this, like, for the reason that haptoglobin binds free hemoglobin, hemoglobin cannot get filtered out of the kidney. So that is the reason why hemoglobin is not normally seen in urine. So it rises in inflammation but falls in hemolytic anemia due to consumption, right? So let's talk about negative APRs. So albumin is the major one. The major plasma protein that drops in inflammation is the liver prioritizes positive APRs. The low albumin, that is less than 3.5 gram per deciliter, is seen in sepsis, liver disease, or nephrotic syndrome. It is a marker of severity. So nephrotic syndrome, you can the differences between nephrotic syndrome and nephritic syndrome are being taught in our renal pathology sessions. You can visit that too. The transferrin, it transports iron but decreases to limit bacterial access to iron. So the low levels are seen in chronic inflammation or malnutrition. The other one, the final one, is transthyretin, that is prealbumin. Transthyretin, a thyroid hormone carrier, drops rapidly in acute inflammation. So low albumin, less than 3.5 gram per deciliter, is seen in sepsis, liver disease, or nephrotic syndrome. It is a sensitive marker of nutritional status and inflammation. The functions of acute phase reactants as a whole is that immune defense, that is CRP and complement opsonize pathogens, while ferritin and transferrin starve microbes of iron, right? In tissue repair, fibrinogen supports clotting, and SAA recruits repair cells. And in inflammation modulation, APRs amplify or dampen immune responses via cytokine feedback. The diagnostics, they are also important in diagnostics, like APR levels guide diagnosis and monitoring. Think CRP in sepsis or ESR in temporal arteritis, they increase, right? So they also drive diagnosis. So that is all for today. Subscribe for more clinical polls, and thank you for staying with me.